I think we can start. Welcome to this virtual roundtable. Our webinar today deals with medical transport and EMS, medical transport in emergency medical services. Everything called emergency medical services in English, EMS, is translated differently in Francophonie. It can be Service Presbyterian d'Urgence or SPU in Quebec, AMU in Belgium, SAMU in France, but all of these are translated as EMS in English. We want to thank all our participants and panelists. You are uh, quite numerous online as well, so thank you very much, and thank you to Accreditation Canada. In the last webinar that we held a few months ago, we had participants from 80 countries across the world. This was very impressive, and we hope to beat that record today. Today's webinar will last between an hour and a half and an hour 45. We'll be looking at a topic that's often forgotten, yet very necessary. We hope to highlight the extraordinary work that's done every day by EMS, by medical transport companies, by crisis management, as well as by uh, air transport EMS. This is what we often call pre-hospital care. So this webinar is the first installment of a series on EMS, emergency medical services. The second webinar will be in English and will happen in the spring of 2025. This webinar, this one will be in French and it is interpreted into English. If you have any questions or if you have any trouble hearing the interpretation, please let us know in the chat. However, you should be able to select either French or English from the globe icon at the bottom of your screen. Today's slides, one presentation will have bilingual slides, but all other slides, all other presentations will be in French. However, we will be sending you through the chat a Word file with the translation of the slides. So it's a little bit easier for you to follow. If you have any questions with respect to the translation afterward, please let us know after the fact. Following this webinar, we'll be asking you to fill out a poll. So please do fill it out. It's very important to us. It will take no more than 30 seconds and it will be after this webinar. Thank you for using the chat for all of your questions, for all the practical questions. However, if you have questions for our panelists, you will have the opportunity to ask questions from our panelists. Please use the Q&A icon. We'll be answering as many questions as we can at the very end of the webinar after we've heard all 4 presentations. So one question I know I'll hear today, and I'm preemptively answering it, we will be sending you all of the presentations. We'll send you the recording of this webinar within a few days, and we'll also be sending you a credit. So you will all be receiving a certificate. Just give us a few days to get these things ready. Without further ado, I will quickly introduce you to our panelists. Our first panelist is Colonel Quentin Grégoire, who is the president of Raisonwal, an association bringing together the 14 rescue zones of the Wallonia region in Belgium. He's also the zone commander of EHP. The second panelist is Sylvain Bernier. Sylvain Bernier is an experienced manager with over 25 years of experience in operational and human resources in EMS. He is also the president of the Corporation des Services d'Ambulance du Québec, and he negotiates collective agreements in Quebec. He's also negotiated contracts with the Corporation of Ambulance Services of Quebec. And our third participant is Propair, represented by Marie-Pierre Thériault, who is currently VP of Technical Services and Quality at Propair. This is a leading aviation company based in northern Quebec. They specialize in air transportation and medical evacuations by air. The second person representing Propair is Annie Trudel. She has 19 years of experience in nursing in various fields, including ICU. And for the past year, she's been the charge nurse at Propair, and she oversees staff, including their continuous education. And our last participant is Chantal Saumur, who's the Director of Quality, Patient Experience, and Professional Practice at Medavie, New Brunswick. She's a nurse by trade, and throughout her career, she's held various positions, including in management. And outside of this, she also provides her expertise as a surveyor for Accreditation Canada and has done so since 2008. She's been a surveyor for Accreditation Canada since 2008 then, and she provides this service internationally as well as nationally. And so without further ado, I'll hand the floor over to Nelia Longu, who's our Executive Vice President at HSO Accreditation Canada. Nelia, over to you. Thank you, Kirill. And hello and welcome to everyone. For some people, it's the morning. For others, it's the evening. We have many participants throughout the world who are connecting with us today to hear our experts talk about their experience in emergency medical services in their region. In Quebec, where I am, emergency medical services are called pre-hospital care, but they are known as EMS in English. This webinar will help us better understand the value of EMS for the overall healthcare system and better understand best practices and implement them locally. Accreditation Canada and HSO mobilizes international stakeholders to improve care for communities. The future of quality requires new approaches. We need to engage people in continuous improvement and continuous learning. I'd like to start this conversation today by underscoring the value of emergency medical services throughout the world in the patient's overall pathway. They help save lives and improve results, and their intervention is indispensable. Emergency medical services do not only provide immediate care to people who are in distress, such as heart attacks, uh, trauma, car accidents, strokes, but they also play an important role in accessing care. I was reading a report produced on G20 countries where access to care remains a challenge throughout the planet. Emergency medical services are a vital link between the community and healthcare systems, especially in areas where access to healthcare, including hospitals, is limited. In many countries, and today we'll hear some, in many countries, then EMS is integrated in the healthcare system, which improves continuity of care. Uh, However, that's not necessarily the case everywhere. And we know that pre-hospital care or emergency care is essential to the continuity of care. They are the first respondents. They are those who initiate the patient pathway. Moreover, it's with great joy that I would also like to add that these services have an economic value because they bring down mortality. They bring down the cost of care over time. Timely interventions can reduce complications and the requirement for more extended care. Obviously, the effectiveness of EMS can vary from one country to the next and from one region to the next and can be influenced by many factors, which is what we will hear from our panelists today. However, their fundamental role in improving public health and safety is recognized universally. And I think we all need to remind ourselves how important EMS are to our overall system. Finally, I'd like to say that accreditation is important as it improves standardized practices in care and encourages a safety of culture and makes sure that people are ready to provide the best possible care in any critical situation. And so, without further ado, I'll hand the floor over to our first panelist, Miss Colonel Quentin Grégoire. Over to you. Thank you. Thank you very much. So you should be able to see my slides. Quentin Grégoire, as Kirill was saying, I am the commander of a region in Belgium, but I'm also in charge of a group that's in charge of firefighting services in Wallonia. Today, I'll be dealing with emergency medical services by ambulance in Belgium. I'll just explain a few legal aspects of our system so that it's easier to understand. I'll explain how decisions are made in EMS and how EMS is structured in Belgium, who are the stakeholders, and a few words on crisis management. So just very quickly, in Belgium, in 1964, a law was enacted, so quite a while ago, and in this act, we made EMS the first trigger to obtaining care from the call to 112, which is our version of 911, up to the hospital. A royal decree in 2007 then defined the notion of the director of EMS and their ambit. And in 2017, this was followed by a ministerial circular on the medical treatment plan and psychosocial treatment plan. And finally, we talk about crisis management, not individual management. And in 2019, there was a royal decree on everything that deals with crisis management and emergency planning, which I will come to later on in my presentation. So we fall under discipline 2 or D2, and I'll explain what that is. It's the medical aspect of crisis management. Discipline 2 was described in a royal decree in 2019. It explains that all tasks are exercised by those that partake in emergency medical services. So those are all of the disciplines that are part of EMS for care and psychosocial care. There are many medical actors, not just EMTs, but also other organizations such as AVIC, which is a an agency to improve the quality of life of community members. So that was just to give you an idea of the structure in Belgium. Now, today we're talking about medical transport in emergency cases, but there's also non-emergency patient transport offered by our groups. For those people don't call 112 or our version of 911, we still look after it, but a dispatcher from 112 cannot dispatch an emergency EMT. Now, today we'll only be looking at emergency calls to 112. So there are 5 disciplines. Discipline 1 is everything that deals with emergency crises. For instance, firefighters, people that structure assistance. Discipline 2 is medical and psychosocial. Discipline 3 is police services. Discipline 4 is logistics. Within logistics, there's a public safety, the army, so defense, and also uh, public works for a municipality. And discipline 5 is information. That is information by the municipal level, provincial level, depending on where the crisis is. So EMS is part of discipline 2 or D2, medical care. So the missions of the medical discipline in Belgium, what does that mean? It's a functional set of tasks that are carried out by various departments. As I mentioned, it's medical assistant, but also psychosocial assistance. So concretely, there we create a chain to provide the care. We provide medical and psychosocial care. We transport those involved. We take the necessary measures to protect the health of the population, and also we set up and manage the necessary infrastructure. So we will create a field post, uh, accommodation center for those involved, a call center, and a data processing center. In Belgium, Discipline 2 is not a structured body such as the firefighters or police. They are a variety of stakeholders that combine their resources to manage a crisis. They are all stakeholders, whether private, public, from a municipal level, a hospital, they are all accredited and authorized to work under the 112 dispatch. They are generally focused on a single patient. So today I'll be talking about transporting a single person generally. So how is that organized? So there's a victim or even a witness who dials 112, our emergency number. Behind 112, uh, there's a dispatcher, and this person will determine whether it's a medical emergency, a, a, a fire, or a police emergency, and then they make the call to dispatch to the correct stakeholder. If it's a medical emergency, the 112 dispatcher will base their decision on the regulatory manual. So based on the symptoms, the disease, the dispatcher will ask a series of questions and will come to a determination whether it's an emergency or not. If it's not an emergency, this person may be pointed to their physician or another clinic, for instance. If it is an emergency, we will send out an ambulance with emergency medical technicians or EMTs. And I'll describe this further, but they dispatch what's required on location and they manage until the patient is hospitalized, until they are admitted to the hospital. and I'll come back to their hospital admission later on. So with respect to the stakeholders in EMS, so at the 112, there are call takers that handle the calls and alert the required discipline and alert the authorities as well, if required, and they dispatch emergency medical care. So they get the call, they trigger whatever the support required is, and they follow the patient and validate where the patient should be sent depending on their pathology or depending on the distance. That's for 112. There are various basic stakeholders under 112. The first one would be ambulance. The staff in the ambulance are emergency medical technicians, EMTs, and they are able and trained to provide basic life support. In Belgium, there are 116 departments, services. I'll come back to this. And overall, because each services could have many units, we have 441 positions and 57 PITs, which I will describe a little later. They're paramedical intervention teams. So these 441 ambulance services carried out 850,000 interventions and overall over 17 million kilometers covered. I'm just trying to explain that on average in Belgium, an EMS call is 20 kilometers on average. That's an average. So out of these 850,000 calls, a vast proportion was carried out by first aid or first respondents, whether they're firefighters or other first respondents. 15% are done by private EMS. They're also accredited. They're accredited by a federal service. And 14% of these missions are done by hospitals through their PITs or paramedical intervention teams, 6% by the Red Cross, 0.6% by National Defense, and some ambulances that depend on municipal funding. That's very small portion, 0.4%. So our PITs, paramedical intervention teams, it's the same sort of vehicle, but on top of two paramedics, there's one nurse that is specialized in intensive care and emergency nursing care. And so advanced life support. And in Belgium, there are 57 of these PITs. If the disease, the pathology is such that it requires a physician, so we saw that in an ambulance and in a PIT, there is no physician. If a physician is required, we can activate a mobile emergency and resuscitation service. This is comprised of an emergency physician and an intensive care and emergency care nurse, both having advanced life support training. And there are 85 mobile units in Belgium as of 2023. It's a car, but it can also be a helicopter. In Belgium, we have two helicopters, one in Flanders, so in the northern part of the country. So one for them and one in the Wallonia area, the southern part of the Belgium. So this is part of a not-for-profit, and it's largely funded either by donations or by subscribers. Now it's been in use for 20 years, and it can be used for these emergency crises type of events, but also for emergency medical transport. So the outfits are based on on their profession, whether they are EMT, nurses, or physicians. Very soon, we'll have an electronic card that will allow us to show our affiliation. And finally, we have hospitals. We talked about PITS, EMS, and physician-equipped EMS. These are all destined to the same endpoint, in other words, a hospital. So they have to be available 24/7. They have to have minimum medical and nursing presence, and they have variable capacity, of course. Now, there can be different specialties. You have the list here. All specialty emergency cares don't require all of these specialties. However, they have to be able to stabilize a patient before caring for them within their walls or transferring that patient towards a hospital that has the required specialty. So that's for the individual mission. Now, just a quick word on medical intervention plans in case of an event where there are many wounded or victims. We have 3 levels: PIM, broad PIM, and maxi PIM. PIM is the most frequent. Five uh, 5 individuals that are seriously injured, 10 people who are injured with varying levels of injury, and 20 people who are in peril. In that case, the manager will send 3 SMUR and 5 EMS. And as you can see, the number of vehicles dispatched grows with with the level, with the expanding levels. So the medical intervention plan has a trigger or a threshold. We have the 112 center. We always ensure that we have a report of the situation that triggers certain actions. We will also triage the victims based on the nature of their injuries, and hospitals can then trigger their own emergency plan. And our discipline D2 will be represented in a coordination committee. So in conclusion, Discipline 2 has several partners. It's not just the Red Cross, of course, it's many partners, public and private, as I mentioned. It's not all of the medical world either. And it's only then emergency medical care, including ambulances, PIT, and SMUR, as well as hospitals. It's it includes the medical chain for management of several patients. It's emergency psychosocial care as well as medical care, and it's a strategic coordination structure as well as D2 is also an expertise in handling highly urgent care. So with that, I'll hand it over to Mr. Bernier. Yes, thank you. Thank you, Quentin. I think everyone can see. So firstly, thank you to Accreditation Canada for giving us the opportunity to speak to the participants throughout the world. I was asked to show you our medical or emergency medical services or EMS in Quebec under the main aspect of quality. So how do we administer the care provided by our paramedics daily? So I'm Sylvain Bernier. I'm the Director of Operations and Human Resources for Ambulance de Mers, an ambulance corporation in the region of Montreal. And we have 30 vehicles and about 200 paramedics that deliver the care every day. I'm also the president of the Corporation des Services d'Ambulance du Québec, the president of the corporation. The corporation means about 60% of the private operators in Quebec. So most of the EMS outside of Montreal is private, and they overall handle 75% of all EMS trips in Quebec. And so we and I, as the president, represent them in negotiations and talks with the provincial government. So understanding that this is an international conference, I wanted to show you Canada. It's a very large country that's comprised of, pardon me, here we are. So we have a vast country, 10 provinces, each having their own EMS systems, including Quebec. Quebec is a French-speaking province that has a population of 8,500,000 people, and the catchment area, the surface area, is almost 1.7 million square kilometers. So it's a vast area, but it is mainly inhabited along the St. Lawrence River, the part you see at the very bottom of the province that runs through basically the city of Montreal and the city of Quebec City. So most of the population lives there, whereas in northern Quebec, and our colleagues from PropAir will be able to speak to this, in northern Quebec, the density is far lower and the area is extremely vast, which means that their reality is very different from what's experienced in the urban areas. In Canada, there is such a thing as universal care. So all of the population of Canada can have access to emergent care freely. Um, Canada is responsible for the overall law, the legislation, the Health Act, and the provinces are in charge of implementing this act. And so we, as EMS, follow the guidelines provided by the province. And we make about 665,000 trips in the province of Quebec yearly, or that was the case 2023, 2024. In the province of Quebec, as I mentioned a little bit earlier, and again, I'm applying the quality lens to the system, we have different types of businesses. Many are private. So these are for-profit companies that provide EMS services. And outside of Montreal and Laval, the situation is a little bit different, and there are more government-based services. So the government essentially provides part of the services, and the rest is provided by private companies. So outside of Montreal and Laval, it's mainly private companies. They can be for-profit corporations, cooperatives. They provide the services daily in the province of Quebec. As Quentin mentioned earlier, in Belgique, there's the 112. In North America, it's 911. Everyone here would uh, recognize 911, and these call takers receive requests for emergency services, and they dispatch the professionals based on the call. So there are different centers. For instance, if there's a need for police services, a police dispatch center will receive the requests. In our case, if somebody dials 911, the dispatcher at 911 will send the call to what we call CCS, health communication centers. There are 9 throughout the province, and these centers handle calls that were first triaged by 911. So a 911 dispatcher determined there was a medical emergency and then transferred the call to CCS. CCS prioritizes the calls based on protocols and allocates resources based on available resources on the ground. So in this case, you see one of these dispatch centers that allocates the resources. As I said, there are 9 such centers. And the corporation uh, that I preside over represents 75% of these CCSs as well. So in Quebec, contrary to what Quentin showed you earlier, in Quebec, things are a little bit different. We have one job title, and it's called primary care paramedic. These paramedics are in the vehicles that are spread throughout the province. We don't have other types of care except for advanced medical technicians, and they are deployed slowly, but they are gaining some ground. We are starting to integrate them, but it's quite slow. We are starting to deploy advanced care. We do hope to be able to develop this, but generally, our service in Quebec is provided by primary medical technicians, and they are spread out through the entire province of Quebec. So in Quebec, access to EMS is provided everywhere. And the care, the quality of the staff, the quality of the training, the protocols that are followed to care for patients are all the same. So regardless where someone is in Quebec, they will access the same type of care. Of course, based on the region, the further you are, for instance, where there's a lower density of the population, access to the service can be slower because the distances are greater. So to be a paramedic, a primary care paramedic in Quebec, one must have a college degree. It's a 3-year degree, post-secondary education. And that includes 105 hours of hospital training and 3 hours of uh, internships in the vehicles, and then, or a practicum in the vehicles. And then there's a national clinical integration program. So after the degree, the candidate has to pass the admission requirements to become a registered emergency medical technician. So that's mandatory in order to be deployed as an EMT. Paramedics, contrary to what we've seen so far, EMTs are in charge of all types of patient transport. So they do primary transport, so in other words, emergency transport, but they are also in charge of what we call secondary transport or non-urgent patient transport. So their status as a paramedic allows them to intervene on all these calls, from the very urgent to the inter-institution transport. In Quebec, there are also medical transportation services, for instance, in wheelchairs, and those do not use EMS. They're provided by other organizations. In order to be a paramedic and to maintain one's status as a paramedic or emergency medical technician, one must be registered in the National Workforce Registry, maintain credentials, and renew this registration every 4 years. And one must also respect protocols and the regional medical supervision. In Quebec, medical supervision is done by the province. The province enacted laws uh, to ensure that training is kept up to date. We also have to respect the assessment process. So we have to comply with the skills requirement and comply our obligation to upgrade our knowledge. There's 16 to 30 hours of mandatory continuous learning that's demanded of paramedics. So we see quality as the main thrust of our efforts in EMS. So there's clinical quality that's supervised at the provincial level, but in which companies invest as well. Of course, there's the operational quality of the company and the administrative quality of the company. And that's determined by performance or by performance metrics that are expected of EMS companies as it relates to their obligations to the state, because our EMS companies have contracts with the province. These are the same parameters for all corporations in the province. So all EMS companies have this same contracts and must meet the same requirements. And it's the same with the paramedics. So it's a provincial formula. So our medical directorate includes a national or provincial medical director. So this person governs the entire province. This person governs the laws for pre-hospital or emergency services, defines national standards for care and equipment. So the vast guidelines that determine the care provided in Quebec and that are administered by paramedics. And the national medical director also directs the roles and responsibilities with respect to medical orientations and skills. So this person is responsible for the standards and rules in terms of care. There are other stakeholders at the government level, of course, that are in charge of administrative issues, but with respect to clinical care, the supervision of the clinical care provided by paramedics, this falls under the National Medical Director. This director also has under them regional medical directors. There's one regional medical director per region in Quebec. You saw that when I showed you the outline of the province, there were a number of regions. So the regional director is in charge of one region and makes sure that the standards are applied correctly in their region. They also assess the quality of the care provided. They ensure that recommendations are followed, and they also ensure that there's an ongoing training and skills improvement in the area. So the regional medical director is in charge of overseeing all the corporations that provide emergency medical services. And a number of reviewers or surveyors work for the regional director. These surveyors will listen to audio tapes, analyze care reports, and report back to paramedics with clinical recommendations. So the paramedics, all paramedics in Quebec, on all their calls, all their trips, they are recorded via a d- recording equipment. And so the director analyzes these calls, these trips, and then provides feedback to the paramedics on the quality of the care they provided and potential improvements. They also produce clinical bulletins to remind paramedics of protocols and of any change in procedures. So the regional medical director also ensures, for instance, that if someone is off work for a while, that they are reintroduced uh, properly. And also, if someone is suspended, given poor assessments, the director, the regional director, will be in charge of reintegrating them in the workforce. So the regional director is in charge of the quality of care on the ground. Now, the corporations themselves also have an interest in providing a good clinical quality. Many corporations in the province have paramedics that are solely in charge of quality assurance. They're in charge of making sure that our young recruits, for instance, that are on probation, provide care properly. They also make sure that if patients refuse care, this is properly documented. There's random assessments and clinical feedback for paramedics. So the people that are in charge of quality assurance are really there to improve the quality. Their sole uh, goal is to improve care. They also provide training videos, and newsletters or bulletins, and their annual clinical reports on various clinical activities, clinical performance, etc. So not only is there a regional review of our care, but there's also an internal review of the care. So these quality assurance paramedics review calls to make sure that they provide that top-notch quality care is provided. And I think that that's quite rare to have quality assurance paramedics listening in on calls to provide timely feedback to improve care. And there's also operational quality. Now, this meets some standards that are imposed by the province. You can see here one of our paramedics who is in charge of making sure that his monitor, his defibrillator is operational. So we have to make sure, for instance, in terms of performance, that our vehicles are checked and back in service within less than 15 minutes. This is because we need our vehicles to be available as quickly as possible. There are also requirements in terms of intervention time, especially for priority areas as they're uh, identified by the centers, the call centers. So priority areas, those calls need to be addressed within 1 minute. Time to hospital, the target is 45 minutes, 20 minutes for triage, 25 minutes for the turnaround of the vehicle. And so that is a short amount of time so that the vehicle can be back on the road as quickly as possible. Those are targets that were set by the government to ensure uh, the best operational performance possible. And our service hours have to be delivered to the tune of 99%. So the requirements are very strict when services are rendered by the various EMS corporations in the province. And there are also surveys. We survey clients or patients uh, to see how they felt about the service. And this is a way for us to oversee quality as well. There's also administrative quality. So there are requirements in terms of administrative quality. We have to ensure that we've properly timed each of the interventions because in Quebec, we make sure that we've timed the moment from the call to the time we reach the patient to their reaching the hospital. So that has to be properly documented. 99%, this is very strict. We have to make sure that we keep proper timing of our calls. And we also have to make sure that our paramedics have taken their continuing education hours, 95% for active paramedics. And we also have requirements in terms of invoicing and reports, which have to be delivered within 45 days. So we have to ensure that we provide timely invoices and reports. We could have had other criteria. There could be a delay, quality, and other types of criteria. For now, these are not administrative quality criteria. However, these are things we keep an eye on because we are trying to improve the care as much as we can in our environment. So the quality of care, as you can see, is seen in a really simple fashion. We have one job title. There's one tiny difference. There's the emerging advanced medical intervention team, but generally they're all primary care EMTs. But there's also the helicopter and airlifting of patients that's being developed in Quebec because we want to continue to provide quality care. But quality truly is the thrust of everything we do. You can see that a lot of energy is invested in managing quality and performance of our EMS. I could have talked for hours about EMS and shown you this in various angles, but we chose to show you very quickly the angle of quality for EMS in Quebec. So, of course, I've understood that the questions would be asked at the very end of this webinar. And with that, I'll hand it over to Madame Thériault.
Thank you very much, Mr. Bernier. Okay. So Accreditation Canada asked us to tell you about PropAir, which has been involved in the accreditation process over the past few years. So we'll be talking about the history of PropAir, our operations, and our work with Accreditation Canada in the various areas in which we operate. So first, we will be talking about an introduction of the participants, Ms. Trudel and me, and the history of our company, our services, our involvement in the community, our challenges, and air medical operations, and Accreditation Canada, which is at the heart of our work. So my name is Marie-Pierre Thériault. I'm Vice President for Technical Services and Quality, which includes the management of a number of sectors such as aircraft maintenance, ground services, so all the individuals who are working at the Rouyn-Noranda Airport, de-icing, luggage services, so everything that's happening in terms of air operations in Rouyn-Noranda. And I also manage the medical department as well as quality assurance. I've been a nurse for the past 14 years. I've been with PropAir for 7 years. I'm still a qualified flight nurse. My colleague, Annie Trudel, will be speaking a little later. She's a head nurse of the air medical department at PropAir. She manages the entire air medical department, equipment, staff, quality, and she will be telling you more about that later. She's been a nurse for the past 18 years. She's been with PropAir for 3 years, and she is also a qualified flight nurse. I thought it would be relevant to talk about the history of our company. Mr. Bernier was saying that our area is very large, and so the history of our company is important. Our company is 70 years old. This was something that was important for me to tell you. So in 1954, Mr. Emilien Pronovo, and just for people in Quebec or in Europe who may know the series Les Filles de Caleb, he is the son of Émilie Pronovo. So Emilien Pronovo had created the Lassar Air Services, and he was working with his 4 children. That company covered a big chunk of northern Quebec, and we carried a lot of workers, scientists, prospectors, geologists who were setting out to discover the North. And we carried a lot of hunters and fishermen. So those are vintage bush planes, as you can see on the picture. They were beavers or twin otters. So in 1981, Emilien Pronovo's sons took over the company, expanded it, and we played a major role in developing the James Bay hydroelectric project. This was a massive hydroelectric project, and there were no roads at the time, so all the equipment, food, staff had to be ferried in by air, including SAR Air Services planes that belonged to the sons of Emilien Pronovo. So the company played a crucial role in developing the hydroelectric project. So in 1981, the brothers decided to take over Air Ficto. This was another regional carrier, and the two companies merged to become Propair. That's when the name was chosen, and the hydroelectric construction projects were winding down, so the nature of demand changed. So the owners sold the bush planes to create a fleet of turboprops. So the fleet included about 40 aircraft, and it was converted to new types of planes that could do the air taxi services. So in 1991, Propair was the first Quebec company to have nurses in the planes. Previously, we took the nurses who were in the northern nursing stations to come south with patients on flight evacuation. So by having nurses on the planes, we avoid losing coverage of communities because the nurse has to leave in order to go south with a patient. Then in 2013, the Pronovo brothers decided to sell, but they wanted to keep the company at the regional level. So Mr. Lambert and his partners, who were local people, purchased Propair, and Mr. Lambert is still president of the company. In 2016, we started a partnership with Air Quebec. This is a very, very important partnership. Air Quebec is a company that serves the Cree communities in northern Quebec. And in 2017, we added yet another type of aircraft, the Beech 1900D that you can see at the top right, given that the demand for services, not only carrying people, but also cargo, kept increasing. Okay, so our services, so Propair offers charter services, mostly charter, whether it be to fly workers into northern Quebec or northern Ontario or elsewhere in Canada. We do a lot of charter flights for mining companies, especially. So this is the inside of one of our planes. We can convert a plane very quickly into an ambulance plane, a medevac plane, back and forth. So you see the ambulance configuration with 2 stretchers and 4 seats. If it were a charter flight, there would be 8 seats and no stretchers. So that's what the inside of the plane looks. We do a lot of medevac flights throughout the territory of Quebec, and we take off 60 minutes following the call. So that is our mission standard. We scramble the pilot and the nurse, and I will let my colleague tell you more about that. And we also have an aircraft maintenance department at our base of Rouyn-Noranda, and we also provide airport services. So we're responsible for all of the airport services at Rouyn-Noranda with our ground services team that deals with cargo, fueling, de-icing, and baggage processing. Okay, so our commitment, our involvement is to serve companies that have no local hospital services. In some regions, there are only dispensaries with 1 duty nurse, maybe a local, an on-site physician, or maybe a remote physician. So Propair serves those communities that can't provide the required care on site, especially communities that are not served by road. And as Mr. Bernier's map showed you, the distances are huge. So we go and pick up these people. And we also work to compensate the lack of air coverage in northern Quebec and Ontario. Yes, there is expanding coverage, but there aren't a lot of companies so far that are working in northern Quebec and northern Ontario to cover all those regions. And we're especially committed to providing services despite the remoteness of First Nations communities. In fact, that has become our main clientele. So our issues. In, so interactions between various job categories. When we nurses are trained in nursing school, we're taught how to deal with respiratory technicians, with doctors, other nurses, and so on. But when you work with Propair, you have to have interactions with all kinds of other professions, like pilots, which is a totally different reality. Um, and for them also, they have to learn how to deal with a number of realities that aren't necessarily part of their usual flight experience. And for the nurses, it's something that's not part of their hospital experience. Flight conditions can be difficult. Sometimes you have like gravel runways. Not all aircraft can land on some of the runways to pick up the patients. Availability of services in remote areas. Sometimes we fly into areas where there isn't even any fueling service or nor de-icing for our aircraft. So we have to stop in another neighboring community for fueling. That's a lot of organization and logistics to make sure that we can fulfill our missions. So as we were saying earlier, Quebec is very large. We have huge distances. Sometimes we have a SCEDEVAC mission. So we schedule in advance, we position the aircraft the day before in order to pick up the patient the next day for an appointment in the south. And then we go back the next day because our crews have a 14-hour duty limit. We can't go beyond 14 hours. And given the large distances, sometimes a single flight would be longer than that. And then the weather, as I was saying earlier, it's completely different from the south of Quebec. Yes, we have snow and cold, but we also have the James Bay ice. When it melts in the spring, sometimes visibility is nil. You can't land in some communities someday because of the melting ice that creates fog. And the lack of qualified staff, I think it's a problem for everyone throughout the province for medical professionals. Our contracts right now, to give you an example, we need pilots that have a certain number of flight hours, and the nurses have to have a certain number of years in critical care with specific training. So it's staff that's harder to recruit. All right, and now I'll turn the mic over to Annie Trudel, my colleague. Hello. Now I'd like to talk about air medical operations. So Propair has two types. So we have the Medevac, and as we were just talking about, the SCEDEVAC. Medevac is on demand, and that's where the 60-minute standard applies. So as soon as we accept the mission, the plane has to take off within 60 minutes. Those are emergent cases, and it's about 90% of our air medical operations is Medevac. So we pick people up who need more care than those that can be delivered in their community. And this is also sometimes people who need to undergo scans, X-rays, diagnostic tests that can be delivered in their community. So we also sometimes do this for palliative care or transplants. SCEDEVAC is pre-planned, and this is for more routine appointments, not emergent. And SCEDEVAC is also for people who are not ambulatory and who can't take a commercial flight for one reason or another. So this is how a Medevac mission unfolds. So I'm just going to quickly summarize how things work on with Propair when we get a request. So the clinic, the local clinic, sends a request to our dispatch, and the dispatch informs the nurse. The nurse has 15 minutes to determine the care that the patient needs. If the nurse needs extra resources, because ultimately to carry out a mission, we have one nurse and two pilots. Sometimes the nurse, depending on the critical nature of the care, they might need additional support like a respirologist, a second nurse, a midwife, or a physician. The nurse also has to assess the equipment, any additional equipment that may be needed. Our planes are extremely well equipped to meet all emergencies, but there's some equipment that we use less frequently, such as respirators or incubators, but we decide at this pre-planning stage what we have to carry. We'll also determine the altitude because the nurse, well, it's new when the nurses are new at Prepare, but they have to determine uh, care in respect of altitude because altitude has an impact on the human body. And then the key is to plan. We have to anticipate everything that could happen. That's why we need experienced nurses with at least 2 years experience in critical care. And it makes all the difference, the nurse's experience and the nurse's ability to adapt to change. So once the nurse accepts the mission and determines the requirements, then they have 60 minutes to take off with the team towards the clinic. Then, once they get to the local clinic, the nurse gets an update on the patient's condition and intakes the patient, tries to deliver as much care as possible on the ground because the cabin is very small and it can be cramped. But the clock is on. There's the 14 hours. We have 14 hours from the moment that the pilots are called in until the return to base in Rwanda. So given the number of miles that we have to cover in the remote areas, 14 hours sometimes goes by quickly. So we get a flight manifest that gives an assessment of the time that we can take at each stage of the flight. And we also have to make sure that the majority of assessment and care is delivered before takeoff. And we also have to take care of our standards. We have to plan and coordinate transportation from the airport to the receiving hospital. And sometimes we have two patients that are going to two different places. So there's a lot of coordination. During the flight, the nursing staff works autonomously without direct medical supervision. And the nurses deliver care based on based on the standards, and we also have um, collective prescriptions to meet emergencies. We have satellite communication that can give us 24-hour access to a head nurse or a physician if necessary, if there are questions or assistance is needed medically. So the nurse has to ensure safety in flight. So nursing staff has to apply Transport Canada regulations, especially for safety of the cabin and patients during the flight. So on landing, the nurse leads one of the most critical part of our missions, our air medical missions. It's transferred to a stretcher. So to make a long story short, that's the way that the person enters the aircraft or leaves the aircraft. And when we do a stretcher transfer, there are risks involved. And this has to comply with each of the safety steps because there can be risks of falls. So the nurse directs the transfer on and off. The pilots are trained to do the transfers, and we explain the steps to the paramedics on the ground as we go, and they also give us a hand to get the patients out of the aircraft. And then the intake is coordinated by the flight nurse and the paramedic team on the ground after they transfer information on the state of the patient. Then they share out the roles during the transport to the receiving hospital. Once at the receiving hospital, a report is provided to the intake team, and we take the patient all the way to the bed, and we make sure that the patient is safe, that they have all their personal effects, that they have access to help if necessary. That's our bed-to-bed concept. We get people from their clinic or their dispensary, from their bed there, and we take them to their bed at the receiving medical facility. So that's why we call it bed-to-bed service. And then we return to base, and once on the ground, and the nurse makes sure that everything is ready for the next mission. So our clientele. Most of our clientele is made up of members of Cree nations. That's about 95% of our missions. Then we work with members of the Inuit community in northern Quebec. Sometimes, as Madame Thériault was saying, we preposition in a community in order to meet requests more quickly. We also get evacuation requests from mining companies, also from Hydro-Quebec. So those would be staff operating the hydroelectric facilities. In the northern part of Hudson's Bay and James Bay, there are still no roads between communities, so all transportation is by plane. So our equipment. In order to set out on our northern Quebec adventures, we need state-of-the-art equipment to cover pretty much all emergencies. Popper provides rapid medical transport. Our cruising speed with our Kinier 100 is 420 kilometers an hour, and depending on fueling, we can cover 2,000 kilometers. So transportation is quick. Planes have state-of-the-art medical equipment, and we cover the entire territory of Quebec. So with our versatile fleet, we can land on short runways, gravel runways, and we can be present in the remotest areas of Quebec. And we are also equipped to work in almost all weather, but we have to meet Transport Canada requirements. So we have a number of medical protocols that promote autonomy for our professionals, because often the nurse is the only medical professional on board. So the nurse has to be thoroughly trained. Ultimately, from the outset, the nurse has a college diploma. She is a member of the College of Nurses. She has 25 hours of continuing education and 2 years of critical nursing experience. That's the starting nurse. And then she receives 40-hour theory training on an online platform, as well as 10 hours of direct in-flight supervision, as well as practical training. We provide all the tools to ensure significant autonomy. We have a lot of training, for example, in intubating patients and intensive care in flight. So the nurse can care for someone who has a broken bone or someone who's had a cardiac arrest or who's intubated. Our medical director helps put in place a number of collective prescriptions that help in delivering medication autonomously on board. The monitoring and intensive care equipment is really state-of-the-art. Popper has chosen the best equipment so we can meet the needs of our clients with the highest quality care. We have a satellite communication team 24 hours around the clock with the ground team. So if necessary, the nurse can communicate with the head nurse or physicians. So as I was saying, we have a wide range of equipment in order to provide care to clients of all ages, regardless of diagnosis, from newborns to elderly patients. We have all the equipment that we require, depending on the weight and the height of people. We carry people who have broken bones or people who are on a ventilator. Okay, so teamwork is the key to carrying out those missions. To talk a little bit about our org chart, we have our Vice President, Ms. Thériault, VP of Technical Services and Quality. We also have a medical director who's a physician who helps set transportation standards, all of the legal issues, gives us the tools so we can work autonomously. Then there's the head nurse, that's me. And I make sure that the nurses are properly trained, that they have the equipment necessary to do their work. I take care of equipment maintenance, the whole the whole department. I make sure it's functional and meets quality standards. Then we have 2 team leaders. We have a 7-day on, 7-day off schedule, and each team leader trains new nurses, and then we have the flight nurses. So this is a process based on teamwork. I'm available around the clock to answer nursing questions and operating questions, and the medical director is also available around the clock. We have access to a range of respirologists, physicians, and second nurses, depending on the critical care required. And we have our in-flight satellite communication. And then we have our ground services that fuels our equipment. We have maintenance. We have the pilots who fly the planes and work with the medical team. We have operations that dispatch the missions and make sure that we have hotel rooms. Flight dispatching is really at the heart of the whole process. So each member of the team is a link in the medevac chain. Everyone knows their work. It's like a choreography. So being a flight nurse with Propair involves planning air medical operations, trying to forecast everything that could happen, assessing the state of patients that are being taken on, deliver care throughout the transfer process, work with clients and their family, and that makes a big difference within Indigenous people. Work with crew members, receive a continuing education, working with adults, newborns, all kinds of patients. We sometimes live in remote areas, and we have to be aware, be familiar with the customs of Indigenous people. We have to be very autonomous and have an ability to adapt, because every day is an adventure. And it also means taking into account the impact of altitude on the human body and on your equipment. We're part of a very close-knit family. Everybody is essential to the success of our mission. So that's what it means to be a nurse at Propair. And now I'll give the floor back to Madame Thériault. Thank you, Annick. So as Annie was saying, we have a number of regulators. First of all, the College of Nurses of Quebec. Those are, we have the College of Physicians, given that we have a physician who's on duty 24 hours a day for collective prescriptions. We have Transport Canada, as we were saying earlier, because we're an airline after all, so we're governed by Transport Canada standards for both operations and maintenance. We have collective agreements and contracts. Some contracts require that certain equipment be present in the aircraft, or that pilots have certain flight hours. Each contract is different. So duty time, the clock is always on as soon as the call is sent out. And so again, collective agreements. Our workforce is unionized, and we also have we are subject to the rules that govern ambulance transport, because as soon as we land, we interact with the Quebec ambulance services, and their protocols are not always the same as ours, and we have to make sure that the process is seamless. So we talked about Accreditation Canada. So why did we choose Accreditation Canada over the past few years? We wanted to improve our customer service. We wanted to improve our processes. We had lots of processes. So we have maintenance, we have ground services, we have operations, we have medical services, and we wanted to standardize our procedures and processes to work in a standard way. And we also wanted to build a process that involved all the teams in order to create collective pride and accountability. So this is our process with Accreditation Canada. It all started in January 2020. We decided to start the process to obtain the basic accreditation. So in January 2020, we provided the documentation. We already had a quality assurance department where we already had a lot of processes documented and so on, but we wanted to know where we were compared to what Accreditation Canada was required. So our medical director and I performed an analysis and of the framework, and we said, let's go. It's a big job that involved a lot of people. So in January 2020 that we received our first on-site visit, and we received the basic accreditation with flying colors. And we realized during that process to obtain basic accreditation that we were not very far from the step up, which was Humentum accreditation. So we decided to go ahead. A lot of organizations wait 1 or 2 years before starting the next step, because it's a full-time job to plan for accreditation. So we again started the next step in February 2020. We prepared a business case, and we realized that it would involve all the departments to an even greater extent, including human resources, all the process of all departments. So we started out, and in October 2023, we got our second audit, our second on-site visit, and we received our Humentum certification. And we're also very proud to mention that we received a very good distinction. So that was in October 2023. So the major challenges that we encountered working in remote regions throughout our work with Accreditation Canada, because we talk a lot about patient partners, client partners. Our clientele is in northern Quebec, so it's very hard to get feedback following our medevacs, because their reality is very different. Sometimes they don't have a telephone. There's no way to communicate with patients to get information on their experience. So that was a bit of a challenge to hurdle to overcome, because accreditation requires a lot of user feedback. That's a very important part of the process. Then Indigenous cultures, that's a reality that we deal with forever at Propert. So we've been working in Northern Quebec for many years, and interdepartmental, cross-department work. We work in a number of sectors, so we deal with emergencies every day, not just medical, but also flight operations and maintenance. And in order to obtain accreditation, that was a challenge to have the availability of the main actors. So our medical director is also an emergency room doctor at the Rwanda hospital. So it was a bit of a challenge getting his time and lining up everybody's time. And then we had organizational issues, so getting buy-in and active participation from all levels, because when we talk about accreditation, at first you think it's just healthcare, but you realize that it deals with the whole organization. So we have to get buy-in from everybody in order to get the accreditation. And then we have all the documentation. We have to make sure that they're aligned with the standards, and then cross-department work, and follow up on past non-compliance. So we have to respond within a certain time. And so that's part of, that's just an extra part of the process. That's part of the accreditation. So what accreditation brought us? First of all, it enhanced the reputation of our organization with our partners, our stakeholders, our clients. So when you see the Accreditation Canada seal of approval on an organization, you know that care is delivered safely. Then we were able to implement standardized work practices to improve coordination. We reinforced internal processes to deliver safe, effective, and client-centered care. We also identified and resolved issues thanks to regular evaluations. So essentially, it's another pair of eyes on quality assurance. We did it previously, but the audit is very thorough. The nurses' notes in flight, the disinfection of planes. The audit is very thorough to make sure that the quality is present throughout the company. And finally, we were able to adopt international standard to guarantee safe practices and reduce risk for patients and employees. So that is what Accreditation Canada brought us. As we mentioned, so the question period will come at the end. So I just want to conclude with a video of a few seconds showing the departure of a medevac mission. Thank you very much. So now I'll give the floor to Chantal Sommier. Hello, and thank you. I'm the cherry on the sundae, or last but not least, however you like to put it. So I'll talk about what we do in New Brunswick in terms of paramedical care, home care, and care for so-called orphan patients who do get primary care from a permanent physician. So we're trying to transform community care. We have a tripartite approach with three types of services. So our acronym is EMANB. Who are we? Well, our operations include Ambulance New Brunswick, the extramural program that is home care, and then NB Health Link. We'll also talk about our experience during the pandemic because there are certain things that we're fairly proud of in New Brunswick. And then service excellence, some colleagues referred to the satisfaction aspect, and our work with Accreditation Canada, especially our framework and leading practice. So who is EMANB? We're in New Brunswick. New Brunswick is the only officially bilingual province in Canada. And we are at the very easternmost end of the country. We are closest to our colleagues in Europe and Africa, and our population has been increasing over the past couple of years, especially through interprovincial migration as well as international immigration. We have about 850,000 people, including 16 Indigenous communities, that about 16,000 Indigenous people. Our median age is 45.4 years. It's the second highest in the country, and that's 23% of our population is aging. So when we're talking about aging population, we're talking about comorbidities and chronic illnesses. We have a model that's truly unique, public-private partnership with the Ministry of Health. Our staff are all unionized, excluding for management. We have a number of partnerships, like everybody else. We have partnerships with the hospital system, with emergency services, police, fire department. We also have an integrated approach that's patient-centered and the accreditation standards at this point. I'm an accreditation visitor, so for patient excellence, the revised standards bear witness to the evolution of Qmentum. We have a mosaic of talents dispersed throughout the province, and so I mentioned the various partnerships, and we also have patient advisors who work with us, who are part of our team since 2018, and who help us in quality improvement. It's a never-ending process for us, quality improvement. And we also have a complete and constant input from our patient advisors. When our visitor colleagues come and visit us, they meet our patient advisors. So in terms of operations, we have over 2,000 staff, over 100 locations throughout the province. We have over 500 vehicles, and we have over 800,000 patient contacts per year, including the 3 clinical entities. So other provinces in the country, I assume that it's the same outside Canada as well. We have an issue of emergency department overload. So our paramedic colleagues come to the door, they try and meet the time standards because their performance standards depend on it. But unfortunately, we have trouble offloading the patient. So it's on the ground reality that I'll talk about later. How do we try with the 3 clinical entities as a team to limit or reduce emergency visits and to redirect to another care modality. So Ambulance New Brunswick was created in 2007. So we have a lot of organizations here in New Brunswick that had a number of ambulance services. And the vision was to have one province-wide service. And of course, so that was created in 2007. We have dispatchers, we have ambulances. It's 911, as Mr. Banya was saying. We have air ambulance. So that's what our colleagues at Popper do. We have a number of scope of practice. We have emergency medical technicians who do transfers that don't necessarily require medical supervision or medical care. We have primary care paramedics, and we have advanced care paramedics. And of course, we have critical care flight nurses. So interfacility transport, I referred to our emergency medical technicians, and we also have rapid response units. When the primary care paramedics need a hand with the services, so those teams are sent in, and these are advanced care paramedics who are able to give a hand. So the purpose of creating Ambulance New Brunswick was to standardize practices, to have single access points for dispatching, and there was a question of pay equity and also creating a single patient record. In 2025, we're going to have electronic patient record. So a key milestone on August 21st, in the middle of the summer, we hit our millionth call. So it's not dollars or nor euros, unfortunately. It's calls, people who needed our help, and we're very happy of having reached that milestone. So to go back to what we were talking about, emergency care overload in January 2022, so that we're in the midst of a pandemic. So we try to find solutions to limit transportation and the risk of cross-contamination and other things. So we created a project together with our emergency room colleagues, and we have our physician partners throughout our services, what we call pre-alert. So pre-alert was created during the pandemic. It involves systematic assessment of patients, namely, so vital signs, presentation, is it trauma or is it medical? And then a consultation happens, and then triage. So as you can see, since 2022, we've had some 200,000 911 calls, and about 56% of those calls didn't require transport. We redirected the patient to another care modality, where instead of the emergency room, we also evaluated all of our files with a view to quality improvement and accuracy and risk management. So 91%. So we did about 16,000 audits, the first portion of the launch, and 91% had no clinical concerns. Of course, we trained our paramedic colleagues with this new system, and there are very, very few interventions that would have required realignment. So we have, on the slide it says the CSP. So this refers to the clinical support practitioner. It's a bit like Madame Tudel. So there is a resource that you can call on. And in that case, there is a consultation, and we use the national triage standards that we use for emergencies. So most cases was so P4 and P5, as we say in Canada. So these are people who don't need to be transported right away. And then we have our extramural program. So that's home care. This was a pioneering program in 1981. It was called the Hospital Without Walls. So the purpose was to free up hospital beds and deliver care to the people who needed it most via returning patients to their homes. So this was the pioneering Canadian home care program, and it was launched about the same time as Quebec's community health model. So there's nurses available around the clock, and we work with all the available disciplines. And so we have a primary care physicians, an advisory committee. So say in a hospital setting, this is an alternative to hospitalization. So there's a coordination center with liaison nurses who are in the hospital setting. When a patient is discharged but needs intravenous treatment, then the patient can be transferred home, and there's a nursing team that will provide the care. We have our other health clinical entity deals with orphan patients who don't have a primary care physician and need care after discharge. Then we work with them. So the pandemic opened our eyes to certain issues that we had within the system and within our populations. And so we had an opportunity, together with the Ministry of Health, to address those very, very major vulnerabilities. So in 2023, our special care homes was created. We have a number of levels of care for long-term care, and those places are not necessarily equipped with nurses or nursing assistants. So there were gaps in care quality, and at the same time, there were a lot of emergency visits for situations that could have been dealt with on site had there been a care team on site. So, for example, elderly people who have urinary tract infections, you don't always have to go to emergency for that. So we've reached 49% of all the facilities that are supported, clinically supported by our teams. So it's 215 long-term care facilities out of 434. So the hospitalization rate has decreased somewhat, and we've also it's 1% of emergency visits, but that's still a lot. Another activities we launched in 2024 is access to mobile X-ray. So in care homes, our elderly people and people with special needs who have reduced mobility, there's a risk of falls. So having to mobilize an ambulance and emergency care for an X-ray checkup is inefficient. So we created partnerships. It's not deployed thoroughly throughout the province because the province is divided into 7 zones, but it's a human resource challenge. We need the radiology technicians. X-rays are mostly pulmonary or hip, knee, and shoulder. So that's how we are able to offer on-site service without requiring a hospital visit. So NB Health Link, that was deployed in 2022. So again, these are for orphan patients who don't have access to a permanent primary care physician or nurse. When the ministry asked us to take this on, we were told that there was a waiting list of 50,000 patients, and ultimately there's a few more. Actually, there were 100,000 orphan patients. So the motto, build it and they will come. So we created the service, and and the demand was there. So we offer primary care uh, with either face-to-face or remote appointments. We do all the clinical assessments that we would do in primary care. We have a centralized um, electronic medical record, and we can prescribe. So the nurse practitioner or the physician can send a prescription directly to the community pharmacy where the patient lives. We have access to all the hospital diagnostic resources because we have partnerships with the health networks, and the whole issue of consultations. So our teams are family physicians, nurse practitioners, and nurses. And the family physicians or the general practitioners, they 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 are still working within the local health networks. We're not going to rob Peter to pay Paul. So we don't want to take them away from their existing networks. So they work with us during their available time slots. And then, of course, there's a call center. So the nurses who are responsible for managing the whole outcomes, as other colleagues mentioned, they have protocols and decision trees to determine whether the care episode ends at a certain point or whether it has to continue, and they have access to physicians for prescription and support. So we try and take the clinical and administrative burden off the practitioners to free up time so that they can spend more time clinically seeing patients. So since the creation, it took us about 9 months to implement NB Health Link. We were told we had 50,000 patients, but the demand is a lot higher throughout the province. We have over 101,000 people who were waiting for a permanent physician link, and we were able to register 64,000, and we're still have 37,000 on a wait list. And together with community physicians, when they have the ability to take on new patients, especially when existing patients pass away or move. So we were able to place 10,000 patients with family physicians, and we have 11 community sites. This is a picture of one of our clinics in Moncton, New Brunswick. In terms of the pandemic, so the pandemic froze everything. We had less surgery, less ambulance and transport and paramedic care, but public health, it became a major challenge to meet all the needs. So we called upon our services and our expertise to create a provincial rapid outbreak management team. So what happened is that when there was a few patients who were positive, and the public health physicians would say, we have to diagnose. We would bring in teams to do the screening, and we would get all the lab results, and we would also help uh, in staging resources to reduce cross-contamination. We also supported dispatching for activities. Sometimes staff just were burnt out, but there was no replacement staff and they couldn't close down. So we deployed staff to provide first-line care. And we did over 70,000 screenings within a year. And when we reported on this activity with Accreditation Canada, it was recognized as an exemplary practice, and we're very proud of that. Satisfaction, other colleagues mentioned that. So when we ask people, are you generally satisfied with our services? The last survey, so since 2018, we've always had over 90%. Sometimes it was 93, 94. And HealthLink, so this is the first survey. So for a first survey just after launch is pretty high, and we're very proud of that. In terms of accreditation, so we had very high results, 98.7% at the last visit. In terms of meeting all criteria, we have a framework. So my Quebec colleagues know who I'm talking about. It's a specialist emergency services framework developer, and having a framework that is ever evolving, that is evergreen, helps us to meet newly emerging needs and identify areas for improvement. So the frame of reference is an example that shows that the quest for excellence is unending. So, as you can see, in New Brunswick, we're not perfect, but we are looking for excellence at all times. We are here for tomorrow. So here you see our colleagues, our ambulance crews, our air ambulance crews, and we are at the heart of our community. And if you ever want to come and visit us, that's our website right there. So thank you very much for your attention. And I will, I guess, give the floor back to Kirill to close. Thank you very much. Thanks to all participants. Today, we heard from people who were passionate, and not just the panelists. You are passionate professionals, passionate about what you do, and you do incredible things. But also, we saw comments. A lot of people wrote. I couldn't keep up with the chat, so we got messages from Cameroon, from Tunisia, from Morocco, from Switzerland, from Belgium. Lots of people, and we are very sorry that it went over time. We had promised that we would finish by 10:45 at the latest. It's already 10:48, but I think that the content of the presentations from our panelists was so interesting and so excellent that I think you will forgive us for this slight overshoot in the timing. So we will have to shorten our question and answer. I tried to group questions. We have raised over 20 questions, and I will try and ask the questions, maybe two or three questions each. The other questions, if you have questions that you really want to ask, please don't hesitate to send me an email, and I will send your questions to the panel.
The questions I heard then, or I saw, and I tried to group them. Firstly, how are your paramedical teams constituted? I know that there's a difference between the European approach and the North American approach. For instance, the involvement of a physician in the paramedical teams. Could somebody please explain? And I know Mr. Quentin Grégoire had to leave. Unfortunately, we won't get any information from Belgium. He won't be able to explain the European vision, but what's the North American vision with respect to how how these teams are comprised? I'll try to be quick. It's a broad question, but I would say that it's a question of care philosophy. In North America, overall, physicians are not deployed out on the field. We focus on the skills and competencies of the paramedics to bring the patients as soon as possible to the hospital. The goal being, according to our philosophy, the goal being to keep the physician in the hospital where all of the services and resources are around him or her. So they would be better able to respond to the needs of a patient than if, for instance, in an aircraft. So we try to have very high standards of care out on the field, despite not having a physician. I'd like to touch upon uh, a question that I saw appear quite a bit in the chat, and it has to do with the advanced care paramedics. Why don't we have them? I'd say that as a corporation, we feel that this should be deployed. We really need to roll out the advanced care paramedics. Quebec, for now, wants to reassess the process, reassess the training before it's rolled out, before uh, the rollout is authorized. There are a number of studies that show that it would be beneficial, but Quebec it wants to take time to review training. If you'd allow me to piggyback on what Mr. Bernier said, I think we should say that in Quebec, the scope of practice for nurses, to give you an idea, is very different from the scope of practice in Europe. So, for instance, we have access to a certain number of tools, and we have a certain number of practices that we can deploy. That explains why perhaps we have a broader set of resources as nurses, a broader set of skills, perhaps, that explain why we don't have a physician on board. We had another question. It was a comparison with what's done in Alberta, I believe. There was a question, it's quite specific on the use of CT scans. Why are those not on board in Quebec? I know that it's quite specific, but perhaps you can touch on this. No, I would say that that's quite recent, the rolling out of CT scans out on the field. That's a project that the government of Quebec is keeping a close eye on. In fact, we're interested in the studies of those who have rolled it out. That's the reason why, for now, the government has not yet given the green light to that kind of project. They're under study. Marie-Pierre, honey, do you have anything to add? No, with respect to that. That's not something that we're addressing currently. So I think we can end it here. We have many questions, very astute questions. However, we want to be respectful of your time, given that we're all very busy. I know that our panelists are also extremely busy and they have other things to do. So in order to free you, we'll end it here. Once again, uh, those individuals that sent questions, please don't hesitate to send me an email. You have my email in the communications I sent for this webinar. If you have any questions, please do send them. We'll ensure that you get an answer. I'd also like to mention that the presentations and the recording of this webinar, as well as the certificate, will be sent out in the coming days, perhaps not tomorrow, but certainly not long after. I also want to thank once again from Accreditation Canada all of our panelists for your excellent presentations and for your work. Thank you very much once again, and let's stay in touch. And please do enjoy the rest of your day or evening, depending on where you are. Thank you.